Good afternoon, everyone, and welcome to our COVID Cleaning the Air and Committing to Care. We're so happy to have you this afternoon, and we were reflecting on, we started this whole series 2 years ago, and really trying to bring, the science, the latest science, and I just have to give kudos to our whole team. We've evolved so much trying to bring you cutting edge, leading edge science solutions. And today I'm really proud to be welcoming our guests for all of the above, the science, the solutions, and some really excellent success stories. So happy 2-year anniversary to the COVID series. Please, you're welcome to go back in time and to our archives and share some of that. We've had the Aerosol Coalition developed since then, of a big group of Kevin's here today, represents us, Val, Krista on that Aerosol Coalition. I'm really happy to introduce our first speakers that we are partnering with at the AIHA and IBEC through the Commit to Care program, and OCal is now a partner, and we're very happy to be a partner and help share again the good tools and science. And just welcome everyone. We're going to invite questions in the chat, but just to let people know, we are going to hold questions for timing and for richness to the very end for a panel discussion. So I did just want to let people know that. A couple of other housekeeping items. We will actually have to check, Tony, if we have the survey to send people at the end. If not, we'll send it along afterwards. So take a look in the chat window. I also wanted to say that we may lose video. We are having less and less trouble with that. So should you not have video, never fear, you will see the slide presentation. We will be posting the videos and the slides shortly, probably next week, to be honest, since we're on a Friday afternoon. Yeah, without further ado, let me introduce our speakers here. Okay. So I think we're starting out with Ken and Larry, and I can't tell you which order. I think it's Larry first. So Kenneth Martinez is CIH and Chief Science Officer of IBEC, an environmental engineer and certified industrial hygienist with experience in leading and conducting large-scale research, managing programs in occupational safety and health and emergency response, and creating and teaching professional development courses. He has more than 33 years of CDC expertise in hazardous agent exposure characterization and mitigation control practices in the manufacturing and healthcare industries. Since retiring from the CDC, served 8 years in the CBRN space as a consultant focusing on national biodetection program. Mr. Martinez is a recognized subject matter expert in biological agents, including infectious disease and bioterrorism agents. We also have Larry Sloan joining him today. Lawrence Sloan. Larry has served as CEO for the American Industrial Hygiene Association since October of 2016. Prior to this, he served as CEO for 7 years at SOCMA, a trade SOCMA, a trade association representing the interests of the U.S. specialty chemical industry. Larry's first CEO role there in January 2005. Larry started his nonprofit career at the Adhesive Sealant Council, a trade association representing the adhesive and sealant manufacturers, and was promoted to his first CEO role there in January of 2005. He led this group for 5 years and then began his career as a chemical engineer. He began his career as a chemical engineer. For more than 20 years, Larry's been an active member of the American Society of Association Executives. In 2006, he earned his Certified Association Executive Credential, and in 2021, he was appointed a fellow. So welcome, Larry and Ken.
Thank you very much. It's an honor to be here, and good afternoon to everybody here at OCal. We're very excited to provide you with an overview presentation on how you and your respective employers can be a part of the Commit to Care. And I want to thank again Kim and all of the other folks that work for OCal, that you are a proud Commit to Care partner, And we're really delighted that you are in the Tier 3 partner, which I'm going to talk about on the next slide. So thank you again for your support. This really is a team effort, and as we continue the grassroots outreach, this is something that's going to only continue to elevate the importance of occupational health and occupational hygiene across the USA and Canada. So this slide shows the various partners that we have received commitments from, and you can see it's a range of occupational health and medical societies, indoor air quality. It's a nice mix of associations. We have held calls with dozens and dozens of organizations in the nonprofit sector, and we continue to garner interest from various stakeholders to consider signing on at one partner level or another. So we're really delighted. You can see Workplace Health Without Borders, which is another Canadian-based organization based up in Toronto. We're very excited about the partnership with them, as well as all the others that are reflected on this slide. As you should know, when you partner with Commit to Care, the first step is to go to the URL that's listed in number 1 on this slide. And there are 3 levels of support. So OCal is a level 3, which is 2, that should be 2C on the slide. You are endorsing, sharing, and leading. But as an organization, so if any of you folks work for an organization, or maybe you're a consultant and you work with other companies out there, those companies can become a level 1, which is just providing their logo to support the Commit to Care website. And then you can add that logo to your various communication materials within your employer. You can go a step further and you can not only endorse, but you can also share, which means that you'll be providing your logo and your name, but you'll also be pushing information out to your respective members or to your employees and other stakeholders that you work with. We will send you information to help you with your e-newsletters, as well as social media posts and the like, and you can push that out accordingly. And then finally, if you want to go to the next tier, that's the endorse, share, and lead. And that's where we would actually have you serve as a thought leader. We would have you engage with us in collaborating on webinars that we could then work together on, that would communicate the importance of the Commit to Care initiative to, again, your stakeholders in your sphere of influence. So each one of these levels of support garners you additional exposure, and we would be delighted to welcome any and all of you in any one of these levels of partnership. So once you become a partner, what are the next steps? It's quite easy. First, we would have you issue a press release, and we will provide you with a template that would help you announce to the world that your organization has taken the pledge, whether it's Tier 1, Tier 3, and that press release can then be disseminated through your channels. If you have some sort of either internal or external communications, either to your employees or to your customers or clients, we would ask that you include mention of your partnership in that particular newsletter. We would then encourage either your members if you're a nonprofit, or your clients or customers if you're a for-profit, to also get involved in the Commit to Care initiative. So individuals that are working for a company can encourage your employer to take the pledge. Individuals who are consultants can obviously spread the word to your corporate clients to take the pledge. And in either of the above cases, those companies would then log in as an employer and follow the lesson plan in order to earn their pledge. Now, you as an individual can also take the pledge directly. It doesn't have to be tied to a corporate or nonprofit employer. So you would log in as an employee, and then you would follow the lesson plan. And then obviously we would ask that you share tweets from both AIHA and IBEC across your social media channels to help galvanize the relationship that you have with us. And then finally, sharing across your other professional networks. You people know people who know other people, and as you spread the word through your contacts, that then will help us garner additional support at the grassroots level. So those are the 6 simple steps to what you do in order to become a Commit to Care partner. And with that, I'm now going to turn the presentation over to Ken, who is going to begin talking through the risk assessment philosophy that is built into Commit to Care. Ken?
Thank you, Larry. And good afternoon, everyone. I, too, am very grateful to have the opportunity to speak with you here today. And It has been an incredible privilege to partner with the American Industrial Hygiene Association on Commit to Care and many of the knowledge products that we've created in the past year and a half. And interesting stories that, I've known Larry now for a year and a half through this project, and I didn't realize he was an engineer. Larry, that's another thing we have in common. No wonder I like you so much. Regardless, let's move on. So we presented Commit to Care in its essence to you at our last presentation, or what was about a month and a half ago. But just to reiterate an important point, is Commit to Care is about a grassroots effort. We were very intentional in creating a message that was very high level, because our goal was to try to level the playing field of understanding. If we can get people to understand some basic concepts about risk assessment, about ventilation, about personal protective equipment, then maybe we can encourage them, or they will be encouraged to have a conversation in their place of work. Employers talking employees, or talking with their customers on a common ground about the things they could be doing to create a safer environment for gathering. So risk assessment is a key component of the Commit to Care program. And this isn't, the OCAL is an occupational safety and health based organization. I know that you have many industrial hygienists working there, as well as perhaps occupational doctors, medicine doctors. So I say this because risk assessment is a key component of what industrial hygienists do. And if you look at the National Research Council picture on the right, risk assessment is about first conducting the research, collecting the data, toxicology, epidemiology, computational methods, and exposure method and characterization strategies, so that we can begin to go to the next phase, which is assessment, where we want to identify the hazard. We want to understand what the dose response relationship is between that hazard and the health impact. After knowing that, then we can conduct an exposure assessment to see if individuals who are exposed are meeting or below that criteria for the dose response. And then we can do an appropriate risk characterization. And then ultimately we shift to risk management. So the bottom line is that information is key in identifying if a hazard may be present, and determining that there is, one, a risk of exposure to that hazard, and two, if that exposure could result in harm. Now, as I mentioned earlier, industrial hygienists are trained to do very similar things, but we don't just identify the hazard, we try to anticipate what the hazard may be to the workforce that we're responsible for. Then we identify through recognition of what that hazard may be. That hazard could be biological, chemical, physical, radiological, and then we evaluate. That's the exposure assessment part, where they talk about in the NRC, the risk management, we talk about it in terms of developing control strategies. So I wanted to make sure that we all understand that risk assessment component, how critical it is here. So once the hazard has been recognized, then as an occupational safety and health community, we all are very much aware of the hierarchy of controls. The first thing we would like to do is eliminate the hazard. Well, with COVID-19, that's really complicated to do, because it's everywhere around us, because people are still sick, they could be asymptomatic, and they're spreading virus into the air. Clearly, we can't do any substitution. We can't replace the hazard. But so what we're forced to address is engineering controls, administrative controls, and personal protective equipment. Personal protective equipment, as you all know, are the last resort. Yet that's what we focused on during the pandemic, the wearing of masks, the wearing of N95s, because we did not really, to any great strength, address the engineering control component. Administrative controls were those social distancing factors, the 6-foot rule, trying to maintain this less density of people that we may be working around. So I'm going to address a few of the topics here on engineering controls that we should be doing. The broader scientific community has recognized that the airborne route of transmission is the primary route. And to this day, CDC has not made that strong statement. They do create or make recommendations on increasing outdoor air, increasing filtration, without specifically saying that they believe the airborne route of transmission is the primary route. So Commit to Care, we took all of these risk factors and risk mitigation strategies and boiled it down. And you heard the story before, but for those new in the audience, when we first got the work through AIHA to help support and create some knowledge products, the first thing I delved into was the risk factors. I was responsible for creating the content, and I created a 9-page document, all science-based. And the first thing on the page was a infectious disease equation. My comm staff laughed at me, called me a nerd, and said, "No, Ken, we can't do this. People aren't going to digest this." So together, we all created what we call the 4Ds, right? The risk factors are about duration, and you in the occupational health community recognize that component. If you're dealing with a chemical hazard, the longer you are exposed to that chemical hazard, the greater the risk of some significant health impact, right? The greater the risk that you'll get above that occupational exposure limit. The second risk factor is density, and very simply put, it's how many people are packed together in a circle. And why that's important, because you don't know in that circle of people if someone is infectious. Are they infected? Do they have the disease? Are they spewing viral-laden particles into the air? Now, remember that even asymptomatic individuals can release viral-laden aerosols into the air. They don't show any symptoms. You don't know if they're sick. And also, we recognize that before you become symptomatic, if you are to become symptomatic, you are still shedding virus at that point into the air. So that creates, in a density of people, a cloud, if you will, concentration of viral-laden particles. So as we spread out the density of people, we stay further apart, that concentration will begin to decrease. So the risk mitigation factors are quite simple. It's about distance, right? The farther you are away from a person, for example, that social distancing 6-foot rule, the less the risk of being exposed to a greater concentration of viral-laden particles around that individual. But we have to recognize that that is not totally protective. There is an abundance of scientific literature that has shown super spreader events where people have been 10, 20, 30 feet away, and yet they still become infected. So as these concentration of aerosols, as they spread out in a room, they tend to want to reach homogeneity, meaning that they want to create some equal balance of particles in the air. This equal balance means that the concentration gets less because the particles get spread out. But again, for emphasis, that distance is not totally protective. So the key thing here is dilution. That's about ventilation, that's about outdoor air, that's about filtration, but it's more complicated than that. And that's what I want to talk to you about here today. Next. So Commit to Care does include a risk assessment tool. It's a web-based tool, and it was based on the IHA pandemic that AIHA produced just this year, the newer version of that. But it's based on the SITSEMA model, where it's not that old a document. It's 2018, and Frank Hurl, the chief of staff for NIOSH, who I know quite well, also an engineer, was co-author on this. But it is a control banding framework for protecting the U.S. workforce from aerosol transmission, infectious disease outbreaks with high public health consequences. Again, 2018, this was 2 years before COVID-19. But for those of you that are familiar with the hazard banding and control banding concepts, it's a very simple way of addressing on a semi-qualitative level or semi-quantitative level, maybe qualitative level, of the risks and how to translate those risks into control strategies. So basically, your risk matrix has 2 axes. One is the daily duration, and the other one is likelihood of exposure. Again, very qualitative factors, except for the daily duration. We go 0 to 3 hours, 3 to 6 hours, greater than 6 hours. So and when you talk about that likelihood of exposure, it has to do with, perhaps you walked into a room with one person. Likelihood of exposure is possible. If you walk into a room or outside, if you're outside, the likelihood of exposure is probably unlikely, because we know that SARS-CoV-2 can only survive in the outdoor environment for a very short time frame, 2 to 4 minutes. So you can actually begin to visualize where you would fit within this risk matrix. Then you go down to the next level, and you can understand your exposure rank based on the E category that you are, and your risk rank. For this exercise, we consider that the risk rank is R2. Maybe it was R3 for COVID-19. And this is because it aligns to the NIH guidance on the risk of COVID-19. So you can actually establish what your control band would be. So once you establish where you fit within that last control matrix, then you can understand where you would populate within the band. So for example, if you fit within the lesser of the control bands, then you must control with the source first. Now, the way SITSEMA presents this is that there is a source, there is a receptor, and then there's a pathway in between. Very simple constructs, but I think it's very easy for people to understand. If you're at a source, what do? Do these things first on the APED. That is vaccination, right? That is people wearing masks. The pathway, you could be exercising some prudent control strategies such as air filtration. And for the receptor, it's not necessary because the risk is very, very low of release. But if we go to the next level of the control band, the source, again, you still do these things first. Apply masks, make sure people are vaccinated. So it could require multiple options. And then in the pathway, that has to do with do these next. There you start considering the ventilation concepts. What are the things that we could do to reduce that potential concentration of viral-related particles in the air? And the last one, receptor, only if source and pathway controls are not effective. So you wouldn't have to wear N95s if, for example, if you're in a hospital and you have an airborne infection isolation room, but if you never go in there, then you know that the pressure relationships maintain concentration within those environments. And if that nurse is only sitting in the nurse's desk, she's likely to not get exposed. But the last one, of course, is that C category where you do all three. You use the vaccination, the mask wearing, the ventilation improvements, and the receptors that could be prudent. This is what we have on the Commit to Care website. It's a very simple abstraction of that Satsema model. All right, it's a quiz. We wanted to educate people on the 4Ds, but also to walk them through this risk assessment paradigm. So you take the quiz. We'll use a restaurant as an example. So people who frequent my organization's building space are vaccinated or can be assumed to be vaccinated. Well, if you're a restaurant owner, you don't know that. Maybe you have an awareness of the vaccination rate in your community, so you can click on that's partially accurate. Takes you to the next question. People who frequent my organization building space generally stay at least 6 feet apart from one another. Again, you're in a restaurant, that's partially accurate. People who frequent my organization's building space wear properly fitted masks. Well, mask mandates have been rescinded in the United States, and therefore people are going to restaurants unmasked. I have been to restaurants where they're still maintaining social distancing. So let's click on the inaccurate. The average time the typical person spends in my organization's building space is restaurant, less than 3 hours. So it takes you to this level saying your risk of exposure is moderate. Again, this is a very an abstraction of the Satsema model, but it educates people through what they can do. And you can see we actually talk about those control strategies, managing the risk at the source, managing the risk at the pathway, and managing the risk at the receptor level. The next thing I'm going to talk about, this is not included as part of the Commitment to Care, but it is shared both by the American Industrial Hygiene Association and by IBEC freely. It was developed by Signature Science. They came to us with this idea, and the reason I was so supportive of this is based on industrial hygiene principles of near field and far field. It's not a Wells-Riley equation that talks about one individual and talks about exposure time, you know, the number of particles in the air, the breathing rate, and so on and so forth. All right, so it's a PDF, but it's all backed by JavaScript, and I'm actually going to walk you through that with you. You may look at this and think, well, this is pretty complicated, but it really is not. You have an A and a B column. This actually allows you to make selections and compare these two selections. So all of the key things that you would be thinking are important. For example, the group vaccination rate, you can click that. How many people are in a space? What is the social distancing that's going on? Are they, 10 feet apart? Are they less than approximately 1.5 feet apart? Are they wearing masks? What type of masks? Are they anything from a fitted N95 to a cloth mask to no masks at all? What is their select vocalization intensity, speaking, singing, being silent? What is the breathing rate? Based on are they sleeping, resting, passive, so on and so forth. It even includes, the important one, the duration of hours. This is all about the duration as part of our 4Ds, and outdoor activities and indoor activities. So if you're indoors, what are the air changes per hour that you may be seeing there? Is there room filtration? Are there no filters? Are there HEPA filters? And then if you go to the very right side of it, calculate the adjustment to the local community's conditions. What's the average daily case rates? And also the variant prevalence includes alpha, beta, delta, and Omicron, which right now, delta is a very, very small percentage, if at all, and Omicron BA 2.12.1, at least in the United States, last I read, is 58% of the cases that we're seeing in this country. Immunity prevalence, and as you click on each of these things, so just for example, if we click on this one, in this group is composed of people who are 100 times lower than the community for A, and we'll go to the extreme 100% since they were known to be diagnosed with COVID-19. Group's vaccination rate, let's bump that to, oh, what are we at now? 68% in the US. Number of people, we're going to vary that to, let's take this down to 2. Take this one to keep that at 10. Social distancing is being maintained for both. Let's see, here people are wearing, and this is the worst case scenario, so they probably know, and here we'll say cloth masks, percent of people wearing masks. Well, given that mandates are rescinded, we're going to put 25% for both. We'll keep all the other ones, the exhalation rate and other things the same. The duration of hours the same, just for the sake of making sure that we get through this. But the point I'm trying to make here is, as you click each one of these options, you can see here on the lower right where it says in the A category, which is the one where we collected 100% lower than the community's average. You can see now you have a lower exposure that's in the green area. But in the B one, where we know people are infected, they're not maintaining social distancing, maybe the air ventilation, basing on your choices, you can see that now it's in a high risk category. So it's a very, very useful tool. Again, you can find this on the AIHA website. It's in their COVID-19 resources, and it's available on the IBEC website as well. Like I said, there's no charge for this. You do have to agree to terms and conditions of use. But there is a publication that's going to be coming out on this very, very shortly. And this is what we term as far as the validation. One thing I'll educate you on is that I've read the publication. I asked them to compare it to a lot of the super spreader events. I think they did a total of 11 super spreader events. The R-squared value, which is the correlation factor, was like 0.92, I believe, for all these 11 cases, which is incredibly, incredibly high. So let's focus a little bit on ventilation. Now, you hear a lot of the conversation saying it's about outdoor air, it's about filtration, but ventilation is more complex than that, right? We have to think about the outdoor air, we have to think about filtration, absolutely, but recirculation is a problem as well, because most central HVAC systems, they are combining both outdoor air and recirculated air within a building. And it depends on the time of year, because what they'll do during the springtime, they'll open up those outdoor dampers because that's free cooling, right? And it is filtered, but you're going to get a lot more outdoor air. But during the summertime when it's hot, you don't want to bring in that hot, humid air because you got to treat it then. So what they'll end up doing is dampering things down. Those kind of things affect the building. You don't want to see people opening up windows all the time, because that will impact the efficacy of the HVAC system. So it needs to be a facility or building manager concern. Pressure relationships are also very important. This is not just for hospitals alone, maintaining, cohort wards of COVID-19 patients or airborne infection isolation rooms. You want to keep under negative pressure. But for a building, maybe if you have individual offices, we maintain those under positive pressure. So it's a safe space, knowing that it's pushing air into the hallway. So, and that's a part, the mixing, that we have to understand as well. So ventilation is more complex than just outdoor air and filtration. Next, under Commit to Care, we've created a couple of knowledge products here. These are checklists for HVAC optimization. Again, bear in mind, these are at a very, very high level. Some of you may say, well, it doesn't go into everything that ASHRAE talks about. We didn't want it to be that way. It's not meant for the engineer. It is meant for everybody to get an understanding of the things that you can do. So it's actually a 3-page document. I'm only showing 2 of the pages here. Next slide here. And then portable air cleaners. We also talk about the importance of portable air cleaners. Where are they important? Where would you want to use one, right? And we talk about good air mixing as well.
Thank you very much, Ken, for the remarks. And I think we're going to wrap things up and turn it back over to Kim.
Great, thank you. Thanks, folks. And again, I think you're seeing, I can't appreciate you enough. You were here in January. preliminarily to talk about you know, the program. You got us on board as a partner. We wanted to dig a little deeper today, and we want to keep you here because the beauty of today's session is sort of, you know, interdisciplinary and international. So we heard, you know, some from American industrial hygiene focused, also engineers, ventilation engineers, and we are going to go to our next speaker from a local here in Ontario, and then our last speaker is a physician in Australia. So we're getting a multidisciplinary and also an international approach. So welcome. Thanks again, folks, and we'll save our panel discussion till the end.